Will do. Thank you very much. Let me get my screen up. Thank you for the introduction. So I was asked to present a case, obviously, on the topic this evening. Hopefully, you can see my screen now. So the topic being neovascular glaucoma, and this was a case which was actually recently treated at Royal Perth Hospital and still undergoing active treatment. So this was a 63-year-old lady who presented with a 5-day history of progressive right eye pain and decreased visual acuity in the right eye about 1 to 2 months ago. She initially presented to the local hospital with complaining of associated nausea and vomiting at the time. Past ocular history was significant for right cataract surgery approximately 3 years ago, and she had a medical history of type 1 diabetes, which was diagnosed approximately 30 years ago, treated with insulin. From the history, it sounded like she had poor follow-up with her endocrinology and was mostly self-managing. So on her initial presentation to the local hospital, she had an intraocular pressure of 68 and they contacted ophthalmology at Royal Perth Hospital and were advised to start treatment, and they proceeded to give 500 milligrams of acetazolamide intravenous and whatever drops they had available, which was timolol and Maxidex at the time, and then the patient was transferred across to Royal Perth. So on initial assessment at Royal Perth, the visual acuity in that right eye was light perception. The intraocular pressure was 55, and there was a very hazy edematous cornea. But what was evident was that there was hyphema in the anterior chamber. And just based on these findings and the lack of view posteriorly, there was a question as to whether this was a uveitic glaucoma, this hyphema syndrome. What became proceeded to go further management, so instigation of further IOP lowering drops, including timolol, brinzolamide, and brimonidine, and underwent a mannitol infusion, which dropped the pressure down to 14. So the patient was admitted for ongoing pressure management at the hospital, and unfortunately, the day one post-admission, the patient was found to be in diabetic ketoacidosis due to nausea and vomiting the day prior, and missed insulin dosing. So fortunately, that instigated consultation with the endocrinology team at Royal Perth, and they were involved early with this patient. So on day one of admission, the visual acuity in that right eye was still light perception due to the very hazy edematous cornea and the blood that was evident in the anterior chamber. What was acutely evident on the day one review was that there was neovascularization, which was asymmetrical on that right side compared to the left, where there was no neovascularization of the iris. There was also no transillumination defects in the iris on the right side, making the initial diagnosis of uveitic glaucoma hyphema syndrome less likely. There was no view to the fundus on that first day, but on the left there was appearance of moderate non-proliferative diabetic retinopathy. So she remained as an inpatient, monitoring that pressure, mainly with medical therapy, so continued on the oral acetazolamide and the topical drops. On the second day, she received an intravitreal Avastin injection, with obviously the treating for the ischemia evidence in the neovascularization of the iris, and had an AC parasynthesis to account for the intravitreal injection. The day 3 of admission, the pressure remained reasonably stable. The corneal edema was improving, the vision improving to 636. That was the first time where a view was able to be obtained of the angle. And what was clear was that there was neovascularization of the angle on the right side, not on the left, and a better view of the fundus, where we could see that there was moderate non-proliferative diabetic retinopathy bilaterally, but no evidence of proliferative diabetic retinopathy in that right side posteriorly. So initial investigations from this, obviously a blood test was done just to check how well her diabetes was controlled, and it was evident very poorly controlled with a HbA1c of 11.3. And due to the asymmetrical nature of the neovascularization of the iris, so further investigation was done with carotid ultrasound, and the pictures on the right just represent the plaques that were seen in the carotid bulbs, the top one being the left and the bottom one being the right. There was about 50% luminal narrowing, but there was no significant hemodynamic stenosis. Radiology suggested further investigation with a CT angiogram, which is still pending. She, after her discharge from hospital, she underwent panretinal photocoagulation of the right eye, and she was seen in the clinic approximately 2 weeks later, but the pressure was still quite elevated at 40. On gonioscopy, the neovascularization had regressed, but there was evidence of synovial closure greater than 180 degrees. She was continued on medical therapy until she could undergo surgery, and that occurred approximately 1 month after her admission, where she had a right Bayervelt tube insertion and a repeat of the intravitreal injection of Avastin. The day one post-operative intraocular pressure was 10. So on her latest follow-up, as you can probably appreciate on the right side, she had an OCT performed, which was not particularly exciting, so it looked actually reasonably good. The visual acuity remained stable at 6/36, but the pressure was still elevated, and is probably due to the suture, which hasn't yet dissolved from that Bayervelt tube insertion. She was continued on the medical therapy until that suture dissolves, and hopefully get improvement in that pressure. But the disc appeared healthy, and the cup-to disc ratio was almost equivalent on either side. So this was just the OCT of the macula, the top image being the right eye, the bottom image being the left eye, and it just represents the macular edema, diabetic macular edema that was evident, and it shows that the right is probably just slightly worse than the left. So in summary, the key points, I guess, from this this case, so it was the management of the intraocular pressure, and identifying and treating the cause of the ischemic drive that was in this asymmetrical presentation. So the initial treatment in this case was the acute medical management of intraocular pressure, and then as a temporizing measure until a surgical procedure could be performed in a Bayervelt surgery. And then it was obviously the secondary treatment of that ischemic drive, which was thought to be secondary to the diabetic retinopathy, where she received the Avastin injections in the right eye and the panretinal photocoagulation. So investigation was obviously taken for the cause of the asymmetric presentation. And asymmetric incidence in diabetic retinopathy isn't actually very common. The literature reports an incidence varying from about 5 to 10%. So it's important to investigate for another cause for asymmetric presentations, and the most common being choroidal stenosis and obviously associated ocular ischemic syndrome and central retinal vein occlusion. There is quite a long list, but just a couple more listed there. So she had that ultrasound scan, and she's also pending a CT angiography to assess for any other sort of obvious occlusion or significant occlusion in the carotid arteries. And then lastly, obviously, is the management of the underlying disease. So in her case, it's the diabetes. So getting the diabetes under control. We had early consultation with endocrinology, and endocrinology will be following her up in the near future as well to make sure that her sugars are well controlled. And then ongoing management, obviously, of the neovascular glaucoma in the eye clinic and the diabetic retinopathy and macular edema, which will be following up in the clinic in a few weeks' time. And that's the end of the case. Thank you if there's any questions.
John, thank you very much. That's a very, very interesting case. I've got one question for you. Why do you think it was asymmetric? Why do you think the neovascularization occurred in the right eye and not the left eye?
Well, I think the initial thought was that there was possibly some...
Okay, the question was, why did you? What did you think? And if you don't have an answer for it, it's fine to say that. But I'm pretty sure I know why.
Yeah. So I'm not 100% sure from the notes that I could see as to, in her case, why it was asymmetrical.
So almost certainly it's because she was pseudophakic in that right eye. So she was phakic in the other eye. She'd had the lens removed about 3 years prior. And when you remove the lens, the angioproliferative and growth factors that are produced by an ischemic retina are often partly soaked up by the lens. You remove that sump capacity, and so all of a sudden those factors can come forwards into the anterior chamber and impact on the iris. It's the commonest cause, actually, of an asymmetric neovascularization of the iris in a diabetic, and it happens 6 months or more after the cataract's removed. So it's just worth remembering that. And I think it's also worth remembering to tell patients that when they've got moderate to severe diabetic retinopathy and you're going to remove their cataract, that if they have any problems, they should come back sooner, because it can sometimes lead to worsening of their diabetic retinopathy. So that was a very interesting case. Thank you very much. Have we got any other questions for John? And John, you presented that very well too.
Yeah, I just want to ask a question, Prof.
Yeah.
In the first presentation, I mean, the first admitted to the hospital, why you didn't do the implant GDD in the first time? Instead, you wait until for 1 month directly, John?
So from my impression, it was to check for the regression of the neovascularization with the Avastin, and to have that PRP done prior to the surgery was my impression as why there was a delay.
I think that's a very good question, Ike. So I was almost going to ask, what was the gonioscopy really like? I suspect most of the angle was closed. And in that situation, as you're intimating, that patient's going to require a GDD. So I think that's a very good question. That patient probably should have been booked for an earlier GDD, basically. But I mean, I'm not sure what would be your opinion, Ike, in that situation?
Yeah, I think that in my experience, yeah, in my country, because the patient usually come in very severe cases, and then we usually do with the anti-VEGF first, yeah, the day the patient come, or maybe we have to wait another day. So because here we have to do, maybe we have to deal with the diabetic first. If the patient have very high the blood pressure, I mean the sugar, maybe we have to wait until the sugar level is normal. So we give the patient anti-VEGF before we did the glaucoma surgery. I think because you need that that patient have the hyphema on the right eyes. So I think it's very important to give the patient with the anti-VEGF first, and then after that, usually we have to do the chronoscopy, whether the angle is open or closed. And if usually the angle, I think for the diabetes is more easier comparing to the CRVO. Is they have a prognosis is more mild comparing to CRVO, and aggressive treatment should be done, and doing the GDD is more I think is more helpful for the patients, and then more successful treatment, and then for save the vision as well for the patients. I think that's my opinion, Prof.
Yeah, I would agree. I think that's correct, Ike.
But I don't know. Usually in Caucasian is more different, because usually they come to the hospital is more mild cases, and then the early stage, comparing to our country here, they usually come in very severe, and then it's very early advanced stage comparing to the Caucasians. So I don't know, John. Maybe you find in more earlier than our cases.
I have had the odd patient where they've had neovascularization of the meshwork and some on the iris, and that's largely regressed with revealing functional trabecular meshwork. And so sometimes those patients can be maintained with just regular anti-VEGF treatment. But if the angle is largely closed or closed, day one, that they're uniformly going to need a GDD, basically. I think you probably get more of those cases in Jakarta.
So I think also the reason her surgery was delayed, she had the diabetic ketoacidosis as well. So I think it was initially planned 2 weeks post admission.
Yeah, right. Well, that was a great case, John. Thank you very much. If you could stop sharing your screen, we will ask Ike, would you mind presenting your talk on the neovascular glaucomas? Thanks very much.
Yeah. So can I start, Prof? Shall I start?
Yes, please. Thank you.
Thank you, Prof. Morgan. Good evening, all doctor. Today is my turn to talk about the neovascular glaucoma. I believe all glaucoma doctor here has been dealing with this refractory difficulty glaucoma. Slide. The neovascular glaucoma has been described in the late 19th century by Weiss. It's a condition in which the eye develops progressive neovascularization of the iris and angle. It is potentially devastating form of secondary angle closure glaucoma and is a common type of refractory glaucoma. It was observed that 46% of the patients were between 60 to 79 years of age of the onset. In Cipto Mangunkusumo Hospital, failure rate of intervention is about 36%, right? The retina ischemia and hypoxia are an underlying etiology, and the most common condition associated with this disease are CRVO and proliferative diabetic retinopathy. There are various etiologies such as ocular ischemia syndrome and tumor, right? Actually, the largest number of ocular and systemic disorder could cause this disease, such as shown in this table, but 3/4 of time of it's caused by 3 conditions as I mentioned earlier. Slide. So pathogenesis of neovascularization glaucoma due to the hypoxia. Hypoxia induces production of vascular endothelial growth factor, VEGF. VEGF is vasoproliferative substance which acts upon healthy endothelial cell of available capillary to stimulate the formation of fragile new vessel. So VEGF is a pro-angiogenesis factor, is diffused forward to the nearest area of available capillary, namely posterior iris, through pupil to the anterior. Other angiogenesis factors are also include to dysterokinase pathway cycle through VEGF, TGF alpha, TGF beta, and TNF alpha. TGF beta known to produce the neofibroblast membrane. So in the right side, you can see on the slide, there is an algorithm, the mechanism of VEGF expression through the hypoxia cell. And then this hypoxia cell will induce high VF1 and then activate the VEGF. And then this VEGF will capture by its receptor and stimulate tyrokinases pathway and produce the angiogenesis. Slide. This the VEGF will capture by its receptor and tyrokinases pathway is starting to do biology activity. As a result, angiogenesis lead to begin, and this goes through 3 pathways. All these pathways and output increase angiogenesis. This angiogenesis will induce new vessel on the anterior iris, and with the myofibroblast, as I told you, that the myofibroblast induced by TGF alpha. And once neovascularization begins on the iris and also in the angle along with its fibrovascular membrane, it will block the angle and create PAS, and pull the iris and cornea into opposition, and thus blocking the trabecular meshwork. And as a result, that will be a secondary angle closure glaucoma without properly blocked. Slide. As you see here in the slide, there's a picture how the ischemia retina will trigger VEGF release and develop neovascularization. VEGF is also a vasopermeability factor, and then the level of VEGF increase as a result of breakdown blood-retina barrier. VEGF stimulate neovascularization, and this neovascularization will progress anteriorly and visible vessel starting near margin on or and the iris surface. As you see here, slide. So you have to put the slide in the lens and the slide and vitreous might serve as a mechanical barrier and balancing the diffusion and between the pro-angiogenetic substance and contra-endogenous inhibitor of the angiogenesis. So if there is a neovascularization more common after the cataract extraction and capsular disruption or after vitrectomy, it could explain the high risk of this disease in which the oxygen from the aqueous humor will diffuse easily to the ischemia retina and lead the iris become hypoxia. And this slide, in down of this slide, there are typical clinical presentation that could be divided into three stages of these neovascularizations glaucoma. In stage 1, they call rubesis iridis. If they are go on, it could become stage 2, called angle neovascularization with the fibrovascular membrane, but the angle is still open. And if there is go on, it becomes stage 3, and the angle will be closed with the PAS. Yes. Slide. So the clinical assessment is very important to neovascularization. It's very crucial to see the clinical feature. Clinical feature is depend on the stage. In the early stage is shown in this the first picture here usually is asymptomatic. In the slit lamp, you can see visible fine thin vessel at the pupillary margin is you can see in the picture here. So very fine, and then the IUP could be normal here. But in the second stage, you can find the eye is become red, painful eye, which is mostly in our patient come with this symptom. And the second in the second below here, so you will see neovascularization become obvious, and with the vascular overlying all over the surface of the iris, and then there are more obvious vessel near the pupil margin, as you see here, called rubesis iridis. Here the vision will be reduced, and also the IUP will be increased gradually or high IUP, and also it become more than 50 millimeter mercury. Slide. So you have also have to do the gonioscopy, because gonioscopy is very important to make sure it is open or partial or complete closure to see there is any neovascularization of the angle. So there is a neovascular in the angle. If you take a look on the right side on the slide here, in the inferior of the angle, also crossing of the sclera. Also you have to see, you can see the vessel, the fine vessel crossing over the trabecular meshwork. And even though the angle close, you also can see the vascular. So it's very important to see the angle if there is no edema cornea. And make sure you have to take a look the fundus if there is any PDR or retinal vessel occlusion or any systemic underlying disease. If we cannot see the fundus, you have to do the USG to make sure the posterior of the eyeball. You have to take a look the gonioscopy and the funduscopy, right? So as I mentioned before, it is important to determine the stage of the disease. Stage 1, called namely rubeosis iridis. So if you see here in the slide, new vessels are detected as small rubeosis and can be found in the pupillary margin and the iris. And then the IUP is still normal and the angle is open. Right? So you see here in the slide, the angle is still open, and then in the margin of the pupil, you can see a small fine vessel around the iris. Right? In the disease is still progress, you can say stage 2 with the iris mild moderate rubeosis, and also you can see neovascularization and the angle as well with the growth of fibrovascular tissue over the trabecular meshwork, so that there is an increase in IOP, and also there is some inflammation can be present as well. This is the angle is still open. You can also call open angle glaucoma in this stage. Yes, slide. So if the disease progressing, you can call stage 3 or angle closer glaucoma. There is neovascularization on the iris and angle, which is moderate to severe, with the fibrovascular membrane with proliferate and contraction of myofibroblasts. This membrane will pull the posterior pigment iris to the epithelium anterior, producing ectropion ovea, as well as progressive peripheral anterior synesthesia. As a result, secondary angle closer glaucoma. There is a possible hyphema with inflammation and with the IUP as can be as high 60 to 70 millimeter mercury, as you see as the picture here. Yes, slide. And there is a stage 4, there is a late stage, and there is a regression, but there is attraction of fibrovascular, but new vessel may be much less visible. Slide. There is another classification which is called from West and Gold classification of the iris and anterior chamber angle neovascularization. This called grade 1 if you see iris a new vessel at the pupillary zone less than 2 quadrant, and you can call grade 4 if you find surface new vessel at ciliary zone and or ectropion ovea more than 3 quadrant, with the PAS more than 3 quadrants. Yes, slide. And you have to know the condition and disease, underlying disease associated with this disease, such as diabetes mellitus and central retinal vein occlusion. Don't forget to see the fundus of this patient. Slide. So the management of neovascular glaucoma is divided into 3. There's the neovascularization. You have to treat the retina ischemia in order to reduce the stimulus of neovascularization by doing the pan-retinal photocoagulation and also intravitreal anti-VEGF injection agent to suppress the neovascularization itself, and then to bring down the high IUP, to improve retinal blood flow by giving the anti-glaucoma medication, and also maybe you need the glaucoma surgery, and also don't forget to treat underlying systemic disease. Slide. So once rubeosis iridis has begun, the primary goal of treatment is to reduce the ischemic drive of neovascularization by doing pan-retinal photocoagulation. It is mandatory to do the PRP because it will destroy ischemia retina and also minimize the oxygen demand and to reduce neovascularization. But the effect is not immediately result. So it needs close monitoring. So the parameter PRP should be more than 1000 burn. The new vessel of the angle begin to regress within few days and few weeks. And then to reduce the amount of VEGF being released also take times. So it needs to follow up this patient. So PRP need more time to do the effect of this. And to do, if you deal with the patient with poor vision of the fundus, you need to do the anterior chamber cryotherapy or combined with anti-VEGF or vitrectomy. Slide. To bring down the high IOP, the patient may require combination of anti-glaucoma medication such as carbonic anhydrase inhibitor, topical or systemic, topical beta blocker, and alpha-2 agonist. Prostaglandin analog are generally not recommended since there is a compromised access to obvious scleral route and may activate inflammation, but are used only when IOP is not controlled. Anti-inflammation agents such as topical steroid drop or cycloplegic agent may indicate to control anti-inflammation and pain. Mioticum could be avoided because it may increase inflammation and worsen synechiae for angle closure. Slide. So we also know that anti-VEGF is very important in VEGF. And this is a specific target therapy that reduce the angiogenetic factor. Slide. There are several anti-VEGF available in Indonesia. There are a lot of marketing here. Bevacizumab, ranibizumab, aflibercept, convercept, and pecatinib. We have a lot of anti-VEGF available in Indonesia right now. Slide. So Beva has been emerged as a young first-line treatment for disease iridis. Quite easy to find a Beva here. This is initial study with to rapid regression of the iris and the angle neovascularization with in the patient with this disease. So if become more successful if we combine with the full PRP. So don't forget, if not only intravitreal Beva, but we have to do also with PRP, right? But the duration is only short-lived. The regression we'll see in the iris and in the angles directly 48 hours last to 10 weeks. So the dose of Beva 1.225 milligram or 0.05 ml through pars plana, we can deliver 24 to 78 hours preceding the surgery. And then using intravitreal Beva, the rapid regression of neovascularization in iris or angle and may help control IUV if the angle is still open. And then it will report it within 48 hours, last to 10 weeks. And we give intravitreally and less than 5% will go systemic circulation. So we have to be careful. If we put and give the Beva, it will go systemic. As you see, slide in this slide in the picture here. Slide. So, but if the angle was closed secondary to synechiae, there is no effect on the IOP, but neovascularization is regress. However, within 1 to 2 weeks, the IOP will increase high with new other neovascularization. So PRP is very important treatment. So you have to follow PRP here. There is a study PRP plus IVB vs PRP alone, which is using the neovascularization with PRP plus combined with IVB group will also regress neovascularization more rapidly comparing with PRP group only. Slide. However, we have to be careful if we give the patient with the IVB, intravitreal BEFA, there are first events such as ocular ischemia, acute stroke, and also there is a reduced blood flow to the retina and choroid. So it is important to evaluate patients for systemic risk factors such as choroid insufficiency, coagulopathy, and poorly controlled diabetic. Right? Delivery method of anti-VEGF agent, not only intravitreal injection, but we can also give the patient with topical administration as well as with intravitreal cameral injection, intracameral injection anti-VEGF. And so we have very difficulty with the patient with very high IUP. Slide. So this is my study with intracameral injection BEFA. I have 19 eye with neovascularization glaucoma due to PDR. We did parasynthesis first before we inject the intracameral injection with BEFA. The initial IUP is about 39 millimeter mercury. 1 week under intervention, the IUP will reduce to 24 millimeter mercury. There was regression. You see here in the picture, in day 7, the regression is only 64%. Only few patients, about 64%. Slide. Actually, there is a video here, but since I cannot share, so I inject. It's very easy to inject and then do the parasynthesis. Very easy to inject BEFA anteriorly and also to do the parasynthesis on the patients. Slide. So the surgical management in neovascular glaucoma. Mainly due to increased risk of failure. There's 3 surgical options: trabeculectomy, tube, and cycloablation. Filtering surgery, there is any relative, I think is still effective, and also, but there is risk of failure due to the severe ocular inflammation and bleeding. And early trabeculectomy with mitomycin is only 53%. But they have very good improved success rate if we give with the intravitreal BEFA with or without PRP. I think we have to do PRP with this patient. We will improve the success rate of its surgery. Slide. And GDD have some success in treatment, especially in situations where conventional filtering surgery has failed. And GDD are usually considered the first treatment option for this disease, but the success rate didn't improve prior PRP and concurrent use anti-VEGF therapy. And there is no much difference between Ahmed glaucoma valve and VS Barfeld implantation. Yes, slide. So Ahmed implant are preferred to help with immediate IUP reduction with lesser possibility hypotony, and Barfeld implant seems to be more effective in controlling IUP, controlling the IUP associated with this disease. Slide. So the use of adjunct IVB with acquisition implant intraoperatively has been shown to be successful, but other reported has the same result. However, some studies revealed that receive IVB and PRP for this disease priorly before the surgery were less inflamed and has lower intraoperative and postoperative hemorrhage. Slide. Actually, this is my surgery. There is a bleeding because I didn't do the IVB before the surgery. So I did the intraoperatively IVB. So I have a bleeding on surgery. Slide. And this is the one that I did the BEFA before 2 days before surgery. So there is a very smooth, safe surgery and then very clean. There is no bleeding at all. Sorry for this slide. So actually I would like to share the algorithm management of neovascularization glaucoma, which similar as I mentioned earlier. So maybe I will skip it and then we'll discuss it later, since I've been talking a lot, Prof. So maybe you can read this from Tanu Dada article. So as conclusion slide. Things one more. Neovascularization is a potentially blinding disease. Is an ophthalmic emergency. Early diagnosis and multidisciplinary systemic approach will be needed. Is to save useful vision in this eye. Timely and appropriate treatment of underlying cause of ischemia and controlling of IUP are key to successful management. Thank you. Thank you, Prof.
Thank you very much, Ika. That was a great talk, a very comprehensive talk on neovascularization. Some great diagrams there, and also you really nicely described the kind of various steps, if you like, or the grades and stages of iris neovascularization. Ika, we have got some questions, and one is from Jonathan Jonathan, who's our excellent fellow at Royal Perth, just wanted to comment on the case that John Alexis presented. And apparently her diabetic ketoacidosis was the problem, and that's why the surgery was delayed. The physicians apparently wanted to delay it even further, but the ophthalmologist at Royal Perth, Jonathan, persuaded them to do it earlier. So that was the reason there.
Yeah.
Now, there is a question which is in Bahasa. I might need...
oh no, there is an absent. There's an absent.
Right.
Yeah.
There's... Now,
there is no question, I think.
no questions, right.
If you take a look here from the algorithm, so maybe Nikki, you can share the algorithms with us. I would like to share the algorithms. I also want to ask you also about the algorithm, Prof. We can share about this one. Yeah, this one, the algorithm here. If you take a look closely, there is a high IUP, and then there is you have to divide it between the clear media and not clear media, right? You see that?
Yeah.
So, yeah, we talked already about the media was clear, is clear. Okay, if the IUP control. So there is medical treatment, and if there is high IUP, maybe we can do TRAP, RGDD. But I think it depends on the cost. Maybe we have to do maybe PRP, or it depends on the cost, of course, yeah. If there is media is not clear, it is interesting. Okay, if due to the cataract, yeah, this is the one that I would like to ask. So we have to do the medical control of the IUP and intravitreal BEVA or cryotherapy if possible, because we cannot see the media on the posterior, and then cataract extractions. But since, as I told you, here in Indonesia, we have very severe IUP, so usually we are afraid to do the cataract surgery. We usually do the glaucoma surgery instead before we do the cataract extraction, or if we can we can bring the IUP down. So we usually combine the surgery. What do you think about that?
Yes, and I think it's worth pointing out that the sort of cataracts you get in Indonesia are very dense cataracts usually. So what you're saying is that you can't see the retina in many of those patients. So there's a definite need to remove the cataract at some point, but to do it safely. And likewise, I don't like to remove a cataract when the pressure's very, very high, unless it's curative. So obviously cases of ciliary block or malignant glaucoma, that's different. But here with neovascular glaucoma, I would be wanting to control the intraocular pressure first. So like you say, obviously treat medically, but then you may need to be inserting a GDD,
Yes.
letting that settle a little bit before you remove the cataract. Or if you're able to bring the pressure down prior to surgery, then do the cataract surgery at the same time as you insert the GDD. And I think the gonioscopy here is very important. It gives you a very good idea of the likely long-term pressure outcome. So if the angle is largely closed or largely damaged, you might as well just put the GDD in as soon as you can. So
Yeah.
I think this is a great flowchart. Thank you very much for sharing that with us, Ike.
Yeah, but if there is the angle, you can see the angle is open, maybe you can do, and then you can bring the IUP down. Maybe you can feel that the cataract extractions first, maybe.
Yes, no, I agree. And so if the angle is open,
Yeah.
and you've got control, and you're looking like you'll get control over the neovascular process with your anti-VEGF or laser. You may not be able to do laser until you actually remove the cataract. So
Yes, yeah.
you'll remove the cataract and then put the laser on. I've got a question for you, Ike. Do you have a favorite GDD?
Yeah, I think it depend on the high IUP. If there is not too high the IUP, so I prefer Ahmed implant. But for the neovascular glaucoma, usually they have a very high IUP, so I prefer to do with the Barfeld or Virna things, non-valve tube.
Yeah, that's good. And it's worth commenting, Werner's own study, which has got several hundred patients from Chiptamango Hospital, a large proportion, I think 25% of those patients requiring GDD had neovascularization. So in Indonesia, it's really quite common. And is that saying something about the incidence of bad diabetic retinopathy? Is the diabetic retinopathy more common than the central retinal vein occlusion as a cause of vascularization?
Yeah, I think in Indonesia is number 7 in the world for diabetic. Yeah, but for neovascular glaucoma due to the diabetic retinopathy, we don't know the prevalence of that. So, but diabetic mellitus in the world is number 7 in. Number 7, I think it's quite a lot. And then we have study in RSCM, yeah, and about 25%. I think I forget about that, but I think it's about 25% of the patient from the diabetic retinopathy has a problem with the I think need the treatment for PRP or something like that, and then 50% of that need the vitrectomy. So it's quite a lot. I think that the study done in the outpatient clinic in the diabetic patients. So it's quite a lot for this patient things. It's not a clinic in the eye clinic. It's quite different. So if in the eye clinic, so maybe the prevalence, it will be more, but it is in the diabetic clinic. 25% has a problem with the eye. So the patient doesn't know if they have an eye problem. So, yeah.
Now, Ike, we've got some questions coming through for you. One is from Randy Kindergarten. Good evening, Prof. Thank you for the presentation. My name is Tono. I'd like to ask about the neovascular. Is there any indication for multiple anti-VEGF injections for patients without any regression of the neovascularization? So would you give multiple injections?
No, we usually give one injection for anti-VEGF, and then we do the PRP, because I think PRP is the important things. But since the effect is not directly effect, it's need take time to do the effect of the regression. So we have to do the anti-VEGF, and then VEGF has the directly effects, since they have an effect in 20. I think I have an effect in 24 hours. Since the theory, the journal just say it's about 48 hours effect. So I think they had and the short lived in only, I think they have a short lived as well, but we have to be careful with the adverse effect if we give the BIFA. So we cannot give multiple injection, but we can give, I think, in 3 times in every month, I think, yeah.
Right. So did you say giving the anti-VEGF 3 times a month, or doing the laser?
Yeah, I think, yeah, for in my experience, yeah, usually I give once, and then we do the surgery for glaucoma surgery. And then after the surgery, I usually do the PRP. Usually they have problem with the macula or the retina itself. So I send the patient to the retina specialist. Usually they have the anti-VEGF injection as well. And that's depend on the retina itself. If they have problem with the retina, they usually given the intravitreal injection for anti-VEGF. And usually that's depend on the retina disease itself. So if the problem with the retina, so they inject the anti-VEGF. So I have patient with, I think they 4 times every month. So we have to be, they get the 4 times every month for anti-VEGF, but every month, not, I think they have a quite subsequent times.
Okay.
What you have, what your experience, and then the visual acuity is quite good. And I have one patient, I think several patients of that. What is your experience?
So our approach would be very similar to yours. We would give anti-VEGF straight away, along with the medical therapy to lower intraocular pressure, and hopefully get some regression quickly and control of the pressure, rechecking the angle. As you say, often there's a bit of hyphema, so if that can clear, recheck the angle, make a decision about likely drainage surgery, and then do that if necessary. And also at the same time, or around the same time, we would refer to our retinal colleagues for a PRP. Now, sometimes the vessels regress just with that treatment. If the PRP is aggressive enough, usually they need several thousand spots, in my experience. And then they may not need any more anti-VEGF treatment, even with a GDD in situ. But sometimes, as you say, they'll often have retinal problems, some sort of macular edema or other diabetic complications, or if they're a CRVO, they may also need anti-VEGF treatment for that. And that's, I think, here we tend to give it probably every 6 weeks or 4 weeks to start with, something like that, and then watch it. But we have another question for you, Ike. This is from Anissa Wiyogo. Thank you for your presentation, Prof. Ike. I'd like to ask when do you consider doing IVB? I think that's intravitreal bevacizumab, I'm assuming. Sorry? Intracam. I think the question is, when would you consider giving anti-VEGF into the anterior chamber rather than intravitreally? Do you have a preference, or what's your experience and sort of suggestions?
I think that's a good question, and also since I'm anterior persons, yeah, so I prefer to do the intracameral rather, because I dealing with the high IUP, so I have to bring down the IUP first to when I want to put in the medications. So I have to do the parasynthesis. So I just bring down, I do parasynthesis. While I'm doing the parasynthesis, I also give the anti-VEGF intracamerally. So, but if you can also do intravitreously if you want, but I think, but in my experience, intracameral is more easier, and also the, the iris neovascularization on the iris also regress immediately today after the intervention. So I can do the surgery more safe and then less bleeding compare without I did the intracameral injection. So maybe for the next after the surgery, maybe they need another intravitreal. So I just let the retina surgeon to do it. So that's depend on the retina surgeon to do it. But the first time when I saw the patient, so I rather do the intracameral injection. But if there is, I think maybe that if phakic patients, yeah, I prefer to do intracameral, but if there is pseudophakic, I prefer to do intravitreously.
Okay.
So, but I don't know, but I think that's a prefer of the surgeon, I think.
Yes, no, thank you. I think that's a very, very reasonable answer. I've got a question for you. About how many neovascularization, iris neovascularization cases would you say see in a week or a month at RSCM Kirana? Do you have any idea of numbers?
I think maybe Virna can answer that question. How many patients? Because what I have I've done in my research, yeah, is quite a lot neovascularization glaucoma in Kirana. In my clinic, outpatient clinic, on Thursday, I think it's about 5 patients a day, new patients coming to my clinic. So, so I think quite a lot of neovascularization coming to Kirana.
So that's in one day. That's, you had 5 new cases.
No, I mean, yeah. So,
yeah.
But I don't know, maybe Virna, maybe you know about that.
Werner, would you like to comment? I'm asking the question because here in Western Australia, in Perth, we might see, Jonathan Lai, you might like to correct me, but I think we might see 1 a fortnight new case of neovascularization of the iris. So it gives you an idea of the scale of the amount of pathology that comes in through, say, a teaching hospital in Jakarta like Kirana. But Werner, would you say, is that common to say see 5 a day in your experience?
Yes, actually it's quite a lot, Prof. I could see that for S4 today, we have already several patients, but it is not a new patient actually, but we know that neovascular glaucoma is one of the common secondary glaucoma in our institution, Prof. So when it is related with my study, it is about 25% of the secondary glaucoma cases is neovascular glaucoma. If we have like about 200 patients, so maybe if it is 25%, so 50 of them is neovascular glaucoma. So it's quite a lot, I think, for secondary cases. So we know that the causes of neovascular glaucoma here is not only diabetes but also like CRVO, quite common as well. So the management will be more complex, I think. Even sometimes today I have patient that with CRVO but neglected, Prof. I'm quite sad for seeing this patient actually, because I could see that the visual acuity now is a knowledge session for the patient. Previously it's about like finger counting, Prof. So then maybe he didn't come for sometimes, and then when he came again, the visual acuity already zero. So quite saddening actually. So we have quite a lot of cases like that, and in my in my experience, I have patients with neovascular glaucoma. Then when we treat them when we treat the IOP and we control the IOP, the regression also occur. So it helps the patient if we could control the IOP. Actually, the regression of the neovascularization also occur other than anti-VEGF. I could see that the regression could happen with the controlling the IOP. What do you think, Prof? Prof, you are mute, Prof. You are mute.
No, that's excellent. Thank you, Werner. It sounds like you do see a lot of new iris neovascularization. It's probably hard to count.
Slide share-nya dimatiin dong. Yeah. That's much better.
Yeah. So it's quite a big, when you say it's 25% of your refractory glaucomas, and you're seeing a lot of new cases each day, as well as the follow-up patients. So it's a surprisingly big problem, actually.
Yeah, bro.
So just as well, you've got lots of GDDs, and you're very good at putting them in, all of you. I've seen you in action. Well, I think I don't see any new questions, and we've gone over time, which is always good because it means there've been lots of questions. And Vernie, you've still got patients to see, and
it is the last patient, Prof. I mean, I already finished about 15 minutes ago, Prof.
All right. Well, thank you, everyone. It's been a really fun evening, and I look forward to the next symposium in a month's time.
We have a photograph, Prof?
Oh, yes. And I also wanted to thank our speakers again, Professor Ika Samantri and Jonathan Alexis. So thank you very much.
Alexis.
Now, Vernie, if you could coordinate the photograph, because I'm not very good at these sorts of things.
Okay.
Or Artie, perhaps.
Dr. Miki, could you do the photo, taking the photo?
Okay, Doc. For all the participants, could you please turn on your camera, please? Okay. We're still waiting for about 1 minute. Okay. Let me begin the screenshot. Everyone's ready? 1, 2, 3. Okay, second page. 1, 2, 3. Okay, that will be all. Thank you, Doc.
Thank you very much, everyone.
Thank you very much.
Thank you.
Thank you, Prof.
Ika,
Thank
Thank
you
you.
so
It-
much.
thank you, John.
Thank you so much,
No.
everybody.
See you next
See you.
time.
Bye.
Next
Thank you,
month.
Prof.
Bye.
See you later.
Selamat malam.